Welcome to this explainer. I'm absolutely thrilled to kick off part one of our series, Decode Healthcare with Harshal. If you're a medical coder, auditor, CDI specialist, or a physician, you know that EM coding can sometimes feel like, well, trying to navigate a maze in the dark. The rules shift, guidelines update, and suddenly you're staring at a chart wondering what actually reflects the work you just did? Well, that stops today. In this 10-part series, we're going to completely uncomplicate the entire process. We're starting right here, right now, with the absolute foundations of EM coding, the medical decision-making framework, and that famous 2 of 3 rule. Here's what we're looking at today. Section 1 covers what E&M coding actually is. Section 2 jumps into the 2023 guidelines of time versus MDM. Section 3 outlines the 3 pillars of MDM, and Section 4 is all about mastering the 2 of 3 rule. Let's get right into it. Section 1, what is EM coding? Laying the groundwork. For this first block of our foundation, I really want you to just clear your minds of all those complex tables and dense rulebooks for a second. Let's strip it all back and focus on the core definition of what we're actually doing here. At its heart, evaluation and management coding is the universal language for assessing patient health. This relies on CPT codes, specifically from the range 99202 to 99499. These codes represent the cognitive services provided by a physician or a qualified healthcare pro. Just like the name spells out, they apply to encounters where you're evaluating a patient's current status and managing their ongoing health. We're not talking about physical procedures or surgeries here. It's all about the brain work, the assessment, and the medical plan.
And what's absolutely crucial to understand is that this isn't just for your standard doctor's office visit. These EM services apply across a huge array of patient encounter settings. Whether you're coding for outpatient hospital, inpatient hospital, urgent care, a skilled nursing facility, hospice, or an ambulatory surgical center, the foundational rules of EM coding span across almost all of them. So once you grasp this core logic, you can literally apply it almost anywhere.
Moving on to Section 2, the 2023 guidelines on time versus MDM. This is the pivotal choice in leveling. So in 2023, the AMA and CMS aligned on a major guideline update that fundamentally shifted how we approach coding an encounter. You now face a very distinct choice when it comes to selecting the final level for a visit. You basically have 2 pathways. On one hand, we have leveling by time. Now, if you go this route, the strict rule is that the documented time has to reflect activities performed on the exact same day as the encounter. It's highly specific to that single calendar day. On the other hand, we have leveling by medical decision-making, or MDM for short. MDM is much broader and applies to all those healthcare settings we just talked about. The one unique exception to keep in mind is the emergency department. Down in the ED, time cannot be used as a leveling factor, so MDM is your only option. But everywhere else, you've got these 2 paths. Now you might be wondering, how do you actually choose between the 2? Well, I like to call this the golden rule of EMM leveling, and it's super simple. Whichever yields the higher level wins. That's it. If time is appropriately documented, don't just stop there. You really should run the MDM calculation as well. Your whole job is to accurately capture the maximum legitimate complexity of that visit. So if time gets you to a level 3, but the medical decision-making actually justifies a level 4, you code the level 4. Hands down, you always select the higher of the 2 levels supported by your documentation. Section 3, the 3 pillars of MDM. Let's build this framework. Since we know we're almost always going to need to calculate MDM to secure that highest appropriate level, we really need to understand how it's built. I want you to think of the medical decision-making framework like a 3-legged stool. All 3 legs are absolutely essential for holding up the true weight of the patient's visit. So here are those 3 specific elements or pillars that make up the columns we use to calculate the final level. First up, the number and complexity of problems addressed. Basically, what is actually wrong with the patient today and how severe is it? Next, the amount and complexity of data to be reviewed. This means looking at labs, imaging, old records, or even conversations with external physicians. And finally, the risk of significant complications, morbidity, and mortality. In plain English, what's the risk to the patient based on the management options or treatments we're choosing? So again, that's problems, data, and risk. Those are the 3 elements you absolutely must assess. All right, Section 4, mastering the 2 of 3 rule and calculating the final level. Okay, so we've got our 3 pillars, right? But how do we actually combine them to arrive at a final code level? It's all about the 2 of 3 rule. To get a final level, you only need 2 of the 3 elements to meet or exceed a specific threshold. Let's walk through this conceptually. Imagine you evaluate a patient, and you've got a moderate problem, low data, and moderate risk. Because two of those three pillars are moderate, your final level is moderate, which maps to a level 4 code, like a 99204 or 99214. If you have moderate problems, high data, and moderate risk, that's still two moderates, so you hit a moderate level. But here's where it gets interesting. What if you have high problems, moderate data, and low risk? You might look at that and think, wait a second, I don't have two moderates. But here is the secret. Because a high exceeds a moderate, we can actually count that high as fulfilling the requirement for a moderate. It's like a cascade effect. So that high and that moderate count as two moderates, giving us a final level of moderate. Pretty cool, right? This entire concept boils down to a super simple, foolproof workflow. You just follow 4 steps. Step 1, assess the level for problems. Step 2, assess the level for data. Step 3, assess the level for risk. And step 4, literally just drop the lowest level. Whatever is left are your remaining 2 levels, and your final code matches those. I always like to think of it as a best 2 out of 3 tiebreaker in a game. You figure out all 3 scores, you toss out the worst one, and the 2 that remain dictate your final victory, or, in our case, your final E&M level. Finally, the wrap-up and what's next. Securing the foundation.
You now officially have the structural blueprint for how evaluation and management codes are built and calculated. Let's do a really quick recap to lock these foundational concepts in so you can carry them into your daily coding. First, E&M coding relies on the CPT 99202 to 99499 range and is all about evaluating and managing health across almost all clinical settings. Second, under the 2023 guidelines, you can level by time, which again must be on the exact same day, or by MDM. But your golden rule is to always choose the higher level to ensure maximum accurate reimbursement and compliance. And third, the final MDM level relies entirely on that beautiful 2 of 3 rule. You evaluate your problems, your data, and your risk, and then you just drop the lowest one.
So we know that problems addressed is the very first pillar of MDM, but I want to leave you with this question. Is simply listing a diagnosis in the chart enough to count it as a problem addressed? Spoiler alert, it is absolutely not. Coming up in part 2, we're going to dive super deep into what actually counts as a problem addressed, using the MEET criteria. Believe me, you won't want to miss it. Thank you so much for joining me today. Keep learning, keep growing, and I'll see you in part 2. This has been Decode Healthcare with Harshal.